Good afternoon, everybody, and welcome. This is Stephanie Hall. I'm with the ESRD NCC, and thank you for taking time out of your day to join us for this COVID-19 webinar. You can go to the next slide. I want to just take a moment before we get into the agenda and then introduction of our speaker. I just want to remind everybody that October 1st was the official kickoff, if you will, for flu season. I want to let you know that it's very important for just all of you to get your flu shots, as well as really trying to promote the flu vaccine season, especially this year with COVID-19. I think our focus has been so much with that, but also it's still very important for our patients and ourselves to get the flu vaccine. Be on the lookout for future information coming from the ESRD NCC, or visit our website. We will be getting some information out very soon to the networks that should be distributed to all the facilities about the flu vaccine. So just a little infomercial there about the flu vaccine. Let me tell you about the agenda for today. What is the call about? Today's speaker is Mary Gruel. She is the education coordinator from Tri-State Dialysis in Dubuque, Iowa. Her topic today will be managing the COVID-19 pandemic in the outpatient dialysis facility. As many of you may know, the attendees are muted upon entry into this WebEx, but we do want to hear from you as the presentation goes on. Please, if you have any questions for Mary, please submit that via the chat or the Q&A panels, because we will have a few minutes at the end of the presentation for questions from the audience. Next slide. So what's this call about? You're going to hear from stakeholders and peers in the ESRD community who are adapting to the COVID-19. They'll share examples and provide real-world strategies for facilities to use. And we're engaged in these bi-monthly calls. As you know, if you've been on them before, we have different topics. We're always changing them, but they are always usually related to the COVID-19. Next slide. So let me introduce our speaker, Mary Gruel, registered nurse and a certified dialysis nurse. She has over 30 years of experience working in-center and acute dialysis. She earned her nursing degree from Northeast Iowa Community College in 1987 and became a certified dialysis nurse in 2005. Currently, Mary is the education coordinator for 3 of the Tri-State Dialysis facilities located in Iowa and Wisconsin. So I'm going to turn it over to Mary, and she's going to share her what she's experienced and how she's been dealing in her outpatient dialysis facility during COVID. Mary?
Thank you, and I would like to welcome everybody to our presentation, which, as everybody is feeling the heat of COVID-19, as it is actually more prevalent right now in our dialysis unit than it was in the beginning. Next slide. So my objectives today will be just to describe and outline strategies of managing patients and staff during the COVID-19 pandemic, identify and present policy updates that were necessary to implement to accommodate the care of the dialysis patient during the pandemic, and then also steps in place and an action plan when a patient presents with a fever or positive symptoms for COVID-19. Next slide. So a little bit about, as Stephanie had said, we have 3 outpatient units. We're owned, we are a freestanding unit, and we are owned by Grand River Medical Group, which is a group of physicians. And we have 3 outpatient units in Iowa and Wisconsin, and we are actually opening our 4th one in the spring coming up. We're a 32-unit outpatient facility in Dubuque. That's our main unit. Our other facilities are only 12 patients. We provide in-center hemo, as well as home therapies, home hemodialysis, and also CAPD. We also provide acute and chronic therapies at 2 hospitals here in Dubuque. And we also have trained nursing home staff to do home hemodialysis in a nursing home in Oelwein, Iowa. Next slide. So just to talk a little bit about the history, and we all know the history, late in 2019, COVID-19 was detected in China. Next slide. We really didn't think anything of it until kind of late February when the state of Washington had their first United States death from COVID-19. They presented really good information on, the death was maybe late Saturday night, Sunday, but they came in and prepared and shared everything with you. And then it was like the pandemic became real. It was scary, and but what was really nice is they shared our step-by-step education, as well as when we implemented the education and the changes, wearing the face mask and all the things that we had to do, we could share with the patients that it was real, that, the first patient to actually die from COVID-19 was a dialysis patient. So that helped a little bit and helped us progress. Next slide. So how did we prepare then? I think it was actually probably the week before that first death. We met with the county public health pandemic discussion panel, and it was a real good education. There was probably about 20 of us. We were just there to listen. The county people, the public health, they had all things in place, and we were just thinking, oh, this can't be real. Well, it ended up being real. So we really, as I share with this, I'm the education coordinator, but I'm not the leader. I'm not the director. So, I follow the director, or our medical director, our physicians. But what we did was we read everything from CDC, from Medicare, NRAA, ASN, and then NKF, and then Network 12. So we're part of the Heartland Kidney Network. So we, and that information changes every day. So one thing we had to prepare our staff and our patients is be humble with us, because it's ever changing. So learning something every day. Next slide. So our staff education, we had to, as I said, continually update, of COVID-19 virus signs and symptoms. They kind of changed. At first, maybe it was a fever and cough, and then it led to more, aches, malaise, some abdominal discomfort, maybe nausea, diarrhea, vomiting. So we had to kind of progress with different symptoms, and then mode of transmission. We got fitted for our N95 mask. We kind of went to the hospitals because we did hospital dialysis, so we got fitted with the cappers at the hospitals, but we didn't have any cappers in our facility at the beginning. And then again, as I said, day-to-day basis, sharing information, every incident that occurred, or any, patient symptoms, or, we would just have to meet as a group, and we have 3 physicians, so 1 medical director, but 3 physicians. And actually one of our newer physicians was just started in probably July, and he was part of the New York City when it first came down. So he's very, very knowledgeable, and has been a great asset for us, and that's Dr. Andrew Bland. We also had, in early, or probably, late March, we had emergency Sunday meeting, because people were scared. It was a panic. Are we safe to even work in dialysis? And all of those questions, and there was a lot of concern. So we had a Sunday meeting with all of our staff and our physicians to reassure you that we're going to protect our staff and our patients at the utmost. And I really commend our medical director, Dr. Whalen, and our director of dialysis, Kate Kern, she's an RN and certified nephrology nurse. She's gone above and beyond to keep all of us safe, getting us what we need. We are not short on any N95 mask and personal protective equipment. We've never really lagged on any of that. So she had to do a lot of extra work to keep that going. Also, staff had to, think of what if your school closed and some of that happened, and what about child care? So I had to kind of keep that in the back of our minds as well. Next slide. And then we had to really work together, stay after when everything kind of hit, and, clean house, so to speak, get rid of any material that couldn't be surface cleaned. We put a signage at the entrance in the waiting room and educated the public, no visitors allowed, and no, all of our people that are supply people, management had to go through and be screened, temperatures and such. We really educated a lot of newsletters and bulletin board updates on the plan of action to prevent the spread of COVID-19, and then really honed in on personal protective equipment and hand hygiene and re-educating patients, on the importance of it as well. And then at that time, we mandated surgical face masks to be worn at all times upon entering the dialysis facility for both staff and for patients. And then to call Tri-State Dialysis if they have signs and symptoms of COVID-19. And we considered a fever of 99.2. And then what we would do then is we would kind of notify whatever physician's on call, and we would triage the plan of action. Should they be screened and sent or stay at home until we can have isolation, and then treatment times changing and allowing for staffing. So it was kind of been like a patient by patient, and it's changed greatly. And that's what, staff even says, we do it this way one day and we do it this way differently. So we'll talk about that as well. Next slide. So we had, like I shared with you, we had great leadership action, and that's what I'm very proud of our leadership, and, a lot of things behind the scenes that we don't even know what our leaders have done. But we do track emergency expenses and, request any FEMA grants. And what's nice is we have in our large Dubuque unit, we have not only myself as the education nurse, we have a QAPI nurse, we have our director, and then we have a nurse practitioner, and then, as I said, we have our 3 physicians. So a lot of hands in and brain work in to kind of maintain continuity of all the action plans that we have. So we watched a lot of webinars. We joined the Dubuque County Long-Term Care group, and that's nursing home facilities kind of group. And then that way we could keep track of how the nursing homes are kind of treating our patients and that are receiving care. And then, of course, we kept updated with our hospitals because we do acute and chronic hospital dialysis. So, we wanted to follow their protocols for the hospital dialysis patients, as well as we had to get, if we were doing isolation, we would have to get all water hookups in all the hospital isolation rooms so we could do bedside hemodialysis for those isolated patients. And then we stayed updated from CDC and our network and Medicare recommendation and requirements. And then also we had to submit for mandation of all of our patients and staff of their COVID status, any person under investigation, our positive, negatives, and deaths and recovered. And we'll go over those in our next slides about how all the kind of our statistics. And then we didn't allow any visiting dialysis patients. So we didn't receive, we used to have several, probably 10 to 12 traveling patients that would come, during the summertime to do maybe one or a week treatment with us. And we didn't allow any of the visitors unless it was like an emergency death or anything of that situation. Next slide, please. And then we updated our infection control policy and isolation policy. And then we also created a pandemic infectious disease COVID-19 policy for all our implemented actions. And then the big thing too was if you had, to kind of educate on our cardiac arrest code, we tried to, if we had a patient that was hospitalized with COVID, we tried to get them to be a DNR, and also just, educated mostly in our isolation room and in the hospital that we would do CPR and medications, but we wouldn't ambu them. We'd want to get them intubated. So, and then we wouldn't be able to bring the crash cart to the room, and then also don our personal protective equipment before entering the room for that code. Next slide, please. So other actions, we wanted to maintain our safety and personal protective equipment. So we always were informing them on, you know, we usually have monthly newsletters, but we were doing weekly COVID newsletter updates just to, you know, maintain, you know, kind of social distancing, and if they can, you know, quarantine themselves, even if they're just to protect themselves. We emailed the nursing homes to keep them informed and kind of telling them, you know, what we're doing, that, you know, we're doing extra environmental cleaning. We're not allowing visitors in our waiting room, and then we're social distancing. And then again, to call us before COVID-19 symptoms arise. And I could say that's pretty good. I say probably 3 or 4 people would come in. They would be afebrile, but all of a sudden they mention some symptom that they have, and we're like, oh, you've got to get out of here. We can't have you in the unit. So it's been better. And then the nursing homes are, you know, to give better communication too. Next slide. And so upon entering the dialysis unit, we have a little station set up with a bell and bleach cloths and a thermometer, and then we have little pieces of paper that have all the COVID questions that are on this slide. So we take their temperature and then ask them those COVID questions, and then they carry that slip along with when they get their weight to the dialysis station. And then we just write on our, we don't have electronic medical records, we have flow sheets still, so we just write COVID questions would be negative and then their temperature. So that's kind of what we do. And as I said, it used to be just sore throat, cough, and shortness of breath and exposure, and then we added more like muscle aches, chills, and then the GI symptoms were kind of becoming prevalent as well. Next slide. So I kind of alluded to our environmental cleaning. So we had a waiting room. It was kind of a gathering spot for a lot of traveling caregivers or spouses, family members. A lot of them had a lot of, you know, good relationships with each other. We had newspapers, magazines. We even had like a puzzle table, a television. So we had to kind of close all that down and get rid of all the, you know, things that we couldn't clean. And then we had to move the chairs in the waiting room so that it's greater than 6 feet. And then what we do is every 2 hours, we have somebody that goes out and cleans all the high-touched areas throughout the unit, especially the handles of the, you know, the doorknobs and such. And then we increased the bleach solution from 1% to 2% bleach and updated the labels. And then we made sure all of our cavi wipes, that the disinfectant wipes, were 70% or greater alcohol. And then we made it go into effect that only, you know, staff could eat, but they had to eat 6 feet apart. And then the patients could not eat in the dialysis unit, and we disabled our water fountain and removed our coffee pots. Next slide. So additional actions, I kind of talked about how the patients needed to wear the surgical face mask upon entering and leaving the facility. And we gave them a new surgical face mask weekly, and then PRN if you felt like, you know, I'm looking at it and it doesn't look like it's being effective, you know, or soiled. We did have some patients that refused to wear them at first, and so they didn't actually have to leave. We just had to have the physician come and tell them, you know, the rationale for that. And then we mandated or really highly recommended our staff, instead of wearing surgical masks, to wear the N95 face mask, face shield, and hair covering as directed by physician. And then at the end of the day, we had 2% bleach totes where we would actually wash our shield and our hair covering with the bleach and then leave them there to dry. And then no nebulizer treatments or testing for COVID-19 in our unit. So if they had to be tested, we would take them into one of our restrooms and test them. And then we would put a signage on the door, and it'd have to stay empty for 2 hours before we could come in and use it again. Now, next slide, please. So then, most generally, when we do any of the COVID screens, we do them. Grand River Medical Group, as I said, is a physician-owned facility, and they opened an off-site respiratory clinic, so that's where we would mostly send our patients there. And I'll probably talk more about that, but they'd go to the respiratory clinic, or we'd send them to ER if they were having symptoms. And then, of course, they have to have COVID screenings before they have any hospital procedures, so that's being done a lot. And then it seems like the nursing homes are doing it once or twice a week. They're doing COVID screenings too. So additional actions too. So we had to move our machines 6 feet apart. So we're a 32-station unit. What we did was we just left the machines as is. You know how you used to change them if they're right or left, fistula or central line catheter. We would just leave them and have to, put the tubing over them more. That way that would keep the machine between them, and that would allow for greater than 6 feet. We also, in our walkway, because you have to walk quite a ways to get into our facility, we put red tape on the floor 6 feet apart so that the patients know that. So it was kind of nice, too, because I actually noticed that today, people would stagger themselves, like if they were in a wheelchair or, if they were standing, they would maintain that 6 feet distance. And then we hung plexiglass between the chairs if we could, but not always. We also hung some plastic shower curtains if needed, as well as we have other, they're kind of like room dividers, but they're plastic that are on wheels that we use too if we had to. We kind of, no meetings greater than 8 people. So we did a lot of Zoom meetings for our coffee meetings, and did a lot of, like our managers meetings, we do Zoom meetings and utilize phone conferences. And also it was I was right in March that I was on the National Kidney Foundation committee, so we had to go live with all virtual. The NKF spring 2020 meeting was, virtual live with Zoom, so that kind of helped me get prepared for that. We also had essential worker letters prepared for shelter in place. We live in a tri-state area, so we have Wisconsin, Iowa, and Illinois, and I live in Illinois, so I had to have a letter in case they were shelter in place. And then we also canceled all non-essential travel. So we had, some meetings set up, of course, were canceled, but we highly encouraged staff not to travel as well. And then our medical director, we had to get in touch with our city bus because they provide a great deal of transportation to our dialysis. So we wanted to assure that they continue that transportation. So we had that into effect, and then if a patient, was COVID positive, they wouldn't go on our city bus, but we would have them be transferred by non-emergency ambulance service. And then also the city bus would only transport nursing home patients from the shared facility. You wouldn't put 2 different nursing home patients. So that helped a lot too. Next slide, please. So our staff screening, when we first started, we just kind of were randomly taking our temperatures. Then we started actually recording them. And then we got word that we better also do questions. So we would do the staff questions if they had COVID symptoms, yes or no, and then we would take the temperature, but we'd also have to have somebody else see our temperature to witness that we weren't working when we shouldn't be working if we were febrile or had signs and symptoms. And we started doing that probably at the end of July. And then we maintain all record keeping of that screening. Now, through this, too, we probably have had 2 or 3 staff people out at one time, usually for either exposure or having symptoms of COVID when it really isn't. Maybe just they had a sore throat or something, but we really treated it seriously. So staff with direct exposure or symptoms of COVID-19 were screened, and then they were off for 10 days and had to have 2 negatives before they came back to work. Then if positive, they would be off for 2 days, but would need 2 consecutive negatives again prior to coming to work. We have had 2 staff members positive, and their average time off for work was for 4 weeks. And we'll share more information of that as well as the patients. Next slide. So then we had to ensure proper isolation for suspected, which is a patient under investigation, and our confirmed COVID-19 patients. So as I said, our Grand River Medical Group created this respiratory clinic so that they wouldn't be coming to Grand River Medical Group clinic and they wouldn't be coming to the dialysis unit if they were suspicious. So that's that off-site clinic. And then our nephrologists set the algorithm of who goes where. Do they go to the ER, to the respiratory clinic, or, stays in dialysis unit separated from patients? And again, that suspected COVID-19 person is that person that's under investigation. And as I said earlier, we wanted to discuss code status with our positive patients. So our first couple patients were at a state where, DNR wasn't really, it was appropriate. So we wanted to make sure we updated our cardexes and then have our social worker, work with the nursing home to ensure, that we maintain that same code status for the patients. Next slide. So initially when this COVID started, we have two N rooms that we could use for isolation. And so that's when we got our 2 N rooms. We hung up clear plastic shower curtains, and we created, our isolation, our PPE equipment as such. And we dialyzed person under investigation. Fortunately, our dialysis unit is connected to Finley Hospital here in Dubuque. And so with attending, the hospital's COVID information, we were able to get a vacant radiology room to convert to a COVID-19 room, which was wonderful. So it was an off-site area, part of Finley Hospital. We took one of our hospital dialysis machines down there, completed all legal documentation, and turned that into kind of like a dialysis treatment room. It's similar to the hospital. So we took our, a hospital machine with the portable RO and maintain that. But that was ours to deal with. Finley, they weren't going to maintain it. So we have to, it's a lot of work. When we're done, we have to bleach everything, the walls, the floor with Swiffers, and it's quite extensive to do, but it's doable. So it's really important. And then if we are using the COVID-19 room, we have to make sure that we leave empty stations in our unit to stay compliant with our 32 station facility rules. So, and now we're doing 2 at a time now. So we have to have, like today, we had to have 2 empty stations, so we would stay compliant with Medicare. And then again, I talked about earlier about both hospitals, all their patient rooms had to have the proper water hookup for potential use for isolation dialysis treatments in their rooms. Next slide, please. So the care of the COVID-19 suspected or confirmed positive. So we kind of started planning on isolate them in our dialysis unit as in those 2 isolation areas. But now we do not have anybody positive with COVID in our unit. We use the COVID room for that. We do use our 2 isolation rooms for patients under investigation that maybe been exposed, and we isolate them. And then we might, keep them isolated for 2 weeks, and if they're negative, we will retest and do a second negative test at the end of 2 weeks. Again, the physicians kind of determine by the type of exposure where they need to be. Unfortunately, our respiratory clinic does the longer, they do the state hygienic testing for the COVID-19 SARS, and that takes 48 hours to sometimes 72 hours. It's very lengthy. The ERs do the rapid one, but we do not do the rapid ones in our respiratory clinic. So that can be problematic because we can have somebody that were kind of a person under investigation, and they ended up being positive. So we're trying to work that out somehow, but it's hard because of the testing and the availability, I believe, of the testing kits. Next slide, please. I guess also if we do have, I'm not sure if my next slides, but if we are doing somebody positive in our COVID room, after 2 weeks, then we start testing them again, and they have to have 2 negatives before they can be taken back into our outpatient dialysis unit too. Some of our supply management. So as I said it before, our director of dialysis has done a wonderful job. We maintain our N95 mask, maintain our surgical mask, and then our isolation gowns. We also have the gowns, plus we have like the little space suits where you get their pants and a jacket, kind of like a one-piece outfit. And then extra face shields, shoe covers, and then our hand sanitizers and disinfecting wipes. We have to maintain them for all 3 facilities. And our ordering technician, she is in contact with our vendors all the time to make sure we're getting as much as we can from them. And then we also keep updated with our county emergency management departments, requesting to be put on the list for those in need of personal protective equipment supplies. We've saved all of our empty hand sanitizer bottles, our Gruel, and then we mark them as to keep the container because we've had a lot of local distillery companies manufacture hand sanitizer solution. Sometimes, you have some that are really runny, like watery. Sometimes we've had some that smell horrible, like a tequila, and some of them that are more sticky, but they do the job, and that's been very beneficial and very complimentary for our community to help the essential people out. Next slide. Also, we instituted CDC guidance for extended use and limited reuse. We could use expired hand sanitizer, bleach and disinfecting wipes. In the hospital, your bleach bottles, your vinegar bottles, are only good for 28 days. In the outpatient unit, we don't have that, so we would bring the outdated ones from the hospital back to be used in the dialysis unit. We have pre-made central line catheter on-off kits that have surgical mask in them, so that was very fortunate we would get 3 of them out, each time we did a catheter patient, and we could preserve those because our patients were wearing them already. And then we would encourage to wear the same mask all day for our staff members. And as I said, we'd give patients new masks, surgical masks, once a week. And then, as I said, again, contacting other companies that make hand sanitizer and purchase what we can in the correct concentration if available. Next slide. So amongst all this crazy change time, we actually had a Medicare survey on site at Tri-State Dialysis in our Dubuque unit. So from August 10th to 11th, they watched us. They visited our COVID room. They were very pleased with our COVID room. They were very pleased that we sought to subtract the patient from our census, so we weren't dialyzing an extra person. And they were pleased with our isolation, like at the end of our room that we were using for persons under investigation, and they liked how we were cleaning everything, and they liked our clear shower curtains because we of course cleaned those between, and so it was actually the best survey we've ever had. So we were compliant with all federal requirements related to infection prevention and control practices to prevent development and transmission of COVID-19, and we received no deficiency. So we were relieved with that and felt good that we were doing everything that we should. Next slide. So here's our, this is the COVID-19 status as of yesterday, I guess. I say the 2nd, but oh no, it isn't. It's not updated. So it is now updated to, So now we actually have 13 positive patients we've had. We've had 2 deaths out of those 13, and that was early on. Not unexpected deaths. They had, a lot of comorbid conditions. Our first death was somebody that had a lot of aspiration, pneumonia, and a lot of infection, urinary tract, just different things. He went down real fast. And then our other lady, she had a calciphylaxis too. So those were our 2 patients thus far, I should say. 5 out of the 13 have recovered, and we have 6 positive patients as we speak now. And there are 3 persons right now that are under investigation. Now, we use that under investigation if they've had like a nursing home outbreak, or if they've, mostly the nursing home outbreaks, if they've had, like one of our nursing homes now has 14 staff members and 2 patients. Now, they're not our patients, and then the 2 most recent ones actually were patients that are out in the community. They're not in a nursing home. But these 2 patients actually were diagnosed yesterday with a positive COVID, and the one patient, he went on, and this is what was the problem is, he went to the ER the day before and had like a cough and maybe on and off temp, but low grade, but no other symptoms. And he went to the ER. They must have an algorithm in the ER, and his symptoms weren't such that they did not want to do the rapid. They did the state hygienic one, or it wasn't the state hygienic one. I think it was just one that wasn't rapid. It maybe was done within 24 hours. So he came in, and we did him in the person under investigation room because it kind of he felt better and such. But we found out once we got him on treatment that he was positive, and then he actually deteriorated. And he's a 41-year-old. He's a Marshallese gentleman that has coronary artery disease and a lot of comorbid conditions, but he desatted, and actually by the time he left by ambulance, his temperature was 105. So it was just really, and his O2 sat was 83%. on, I think more with activity, but he deteriorated. And I see now that they're using a lot of that, treating him with the convalescent plasma. So, and I'm not real familiar with all of that. Also, we have not actually dialyzed any acute end-stage kidney disease patients. So we've not started anybody that was healthy and then developed COVID-19 and developed acute kidney failure. We haven't really had new patients because of the COVID-19. We've had 2 actually staff members, which is not bad for a census of 52, and they both recovered. Both took about 4 weeks to recover and get 2 negatives, but they have recovered. Next slide. So now, of course, Stephanie talked about the influenza season. So what's fortunate enough, we have probably about 90% of our patients have received their vaccine. We gave that out the week of September 21st, and we give all high-dose influenza vaccinations to all of our patients. And then we facilitated our employee flu vaccine clinic started September 28th. We have probably about 60% of those, which is good. Our facility offers on-site clinics, so next week will be another one. So hopefully we'll conduct that or get that completed to 100%. And then also, so what are we going to do for the flu season? Well, we don't really know until it comes and we figure out the symptoms, and then we're probably going to, instead of doing a COVID screen, we'll add the influenza A and B screen testing when the physicians feel the need that it needs to be initiated. So again, we'll just have to add influenza to the screening and go with that. Next slide, please. Oh, and then finally, so we ordered our capper, so our Max Air Capper helmet that has the airflow, and we ordered that in March, and we just received it September 20th. So we wear that when we're caring for our positive COVID-19 patients. We had all staff fitted and educated on the use, and then if we highly want it used with our COVID, in our COVID room, and then so we have 3 of them, which isn't really enough, I don't think. Plus, the battery life is 10 hours. So if you're doing 2 patients, you're going over that 10 hours. So at least we got those. We're ordering more, and we also are ordering more battery packs so we can accommodate, somebody that's doing 2 patients. And also then, as I said, I didn't share that. So our COVID room, we moved another hospital dialysis machine with an RO, portable RO. So now, because we have the 6 patients, we're doing 2 patients at a time in the COVID room. And it's a big enough room to, the only thing, it was our first day that we did the 2. We're hoping we don't have power problems. That was the only thing we were concerned about. And we'll see how that goes, and I'm sure we'll remedy it if it is a problem. Next slide. And so infection control audits are continuing. We always have done 1 patient care tech and 1 nurse complete some infection control audits. So we're continuing with those. So again, proper glove changing and hand hygiene between dirty and clean tasks. And then one of the big things we have to work on, and always, is patients sanitizing before they touch the scale. We have hand sanitizer there, but we have to encourage that. And then when they leave our dialysis, their dialysis station, they have to use hand sanitizer. So those we really keep an eye on that, and then we kind of do more educational newsletters on that, and we actually have signs on our bedside tables that have to be 6 feet from the patient, but they, to remind them to do that. And then another audit is gloves being worn when we touch the machine, tubing, the patient's belongings, like their blankets and stuff. We always, because we've had, another talk could be on bed bugs and scabies. stripped used tubing needs to be placed in the bio bucket, but that bucket needs to be 3 feet from stripping it, so we're not carrying all the bloody tubing all around. And then the big audit, too, is are we donning and doffing our personal protective equipment when we're doing the isolation? So, you know, watching that real close, we encourage double gloving so that when you doff all the stuff, you can use the last one for taking off the proper way. So educating that and making sure that we're doing that properly. And then, you know, re-educating. You know, one of the big things that we practice in our unit is culture of safety so that we can clarify and correct anybody to maintain what we need to do and follow our standardized care. And that has been the greatest thing, standardized care, so we're all doing everything the same. And then culture of safety where we can feel comfortable correcting anybody. It's come a long way, so that's real important in our unit. Next slide. It's additional, you know, audits then, you know, are we wearing both our face shield and our N95 mask? We played with it a little. We used to say we could take our face shield off if we're not doing patient care. But then when the increased numbers of COVID came in, we have to wear it all times, face shield, N95, even if we're, you know, just working on our charts. And then also we audit the daily staff temperature logs. That can be kind of, you know, forgetful if you're ready to leave and get out of here to, you know, to make sure we take our temperatures. We want to make sure our patients are wearing the proper surgical face mask and wearing them properly. You know, that's the most annoying thing, but they're pretty good. But, you know, sometimes they'll have it, you know, underneath their nose. So you have to get them back up. And then it's like you have to educate even the public on that. That's horrible. And then, again, our isolation PPE properly conducted. Next slide, or maybe it.
Yep.
There.
Okay. Well, first of all, Mary, thank you very much for that excellent presentation. And I just want to say, you know, congratulations and kudos to your staff and yourself and your team for having a deficient-free survey, not only on a regular day, but during our pandemic. I mean, that really shows a lot about your staff and your management and your whole team. That's really, really awesome because
thank you.
I think that's a hard thing to do normally. So, you know, good for you. We do have a couple of questions that came in, so let's jump into a couple of them. One come in. It said, "Can you speak more about how your unit managed patients and staff that may not have been compliant with some of these rules?"
Okay. Well, staff had no choice. Staff had no choice. You know, and I guess, you know, like I said, it was really, really hard at first because we were, for one thing, we were exhausted. We were sweating. You know, our drinks had to be in an office where you had to leave the floor to get drinks, so we were getting dehydrated. So our physicians were good. They lowered the temperature in the unit by 2 degrees because, you know, you're supposed to keep it, I don't know if it's 70 or 72, but we lowered it 2 degrees. And then our medical director, all of our physicians wore masks, so you had no choice. And then they're better now. The doctors weren't good at wearing the face shield when they make rounds, but they wear them now. So again, I think it all starts with your leadership staff too. They see us doing it, so they have no choice. Now, patients' noncompliance, we didn't have a lot of non-compliant patients. We had a few that wanted to, you know, do the cloth homemade mask, but that wasn't an option. And once you explained it, they understood. There were a few. I remember the first day when we heard about Washington State, and we were in the waiting room, like, you know, taking all the you know, kind of preparing the waiting room and getting rid of all this stuff, and then telling them that one of the patients they had they were very protective family members, but they were always causing, I don't think the patient wasn't real unstable, and they had a lot of different family dynamics. So when they came with probably 5 people from different homes, and, we had to tell them they couldn't do it anymore, that they could not come into the unit. And they kind of festered a little bit, but explained them, the person that died was a dialysis patient. So that took a while to kind of squelch her, but otherwise, all the patients are compliant. The only thing that they don't do, and it's hard now, even for all of us, healthy people, this quarantine or social distancing is hard. And as, we just found out with having our latest 2 people that are probably more, out in the community more, or something that had got that. I hope that answers your question.
Thank you. I do have another question that came in. It says, do you mind sharing how your isolation room is ventilated? And also, are you allowing patients to remove masks for the meds or a snack for diabetics?
Okay. I really don't know the ventilation.
Okay.
Because I know that although, so our isolation in our dialysis unit now is only for person under investigation. There is no different ventilation. But then in our COVID room, that's a good question. And that's something that I'll write down myself, because I know when I was doing somebody in the hospital, they had that, and I don't know what it's called. It's so the air doesn't, or what is it called? The air exchange.
A negative flow.
Negative flow. And I don't believe that we have that in place. So good question. Thank you for thinking of that. And then what was the other one?
Just with, let me see. How do you allow patients to remove the mask for like their meds, or if they're diabetic for a little snack?
Yeah, we don't. The diabetics, we just usually give high C or this one's Neprol or something, but not on a normal basis. So no, they're not allowed to remove their mask unless we're there and giving them their meds. Yeah.
Right, thank you.
And like I said, and then they're down like this, so we do have to remind them. And they're hard sometimes, and people's faces are different sizes too, that I think they don't intentionally do it. Well, some of them maybe do, but yeah.
Okay, I think we got time for another one. What changes in the staff schedule did you have to make when your staff either had symptoms or had a direct exposure? How did you handle those staff coverage? Right.
So, as I said, our leadership staff, so our director, myself, and our QAPI nurse, we've been working full-time staff and training new people, and so we're filling in those gaps. Wow. Which was difficult, especially summer vacations. And then so we were working short, all hands on deck, nurses doing technician jobs, doing machine cleaning. The doctor walked by and he said, what are you doing? You're cleaning, you're just doing whatever you have to do to get the day done. And then it's one day, thank goodness. And you think, I'm going to do it all over again. Yeah, all hands on deck.
True. One more question. Mm-hmm. CDC does not recommend shoe covers. Why did your facility choose to use them?
Just because if it's airborne, it could land on your shoes, is what we felt. So we use it. And I feel more comfortable with that, especially we are cleaning. So when I'm done, I'm cleaning with all that, we take 2% bleach and we kind of just throw it on the floor and we take a Swiffer and we really clean it. So I feel more comfortable with that. So it's just what we decided to do. But thank you for letting me know that, CDC. I know we all feel more comfortable with doing that.
Right.
Yeah.
Okay, that's great. I'll get another question. Did your facility disclose whether there were positive patients treated in the unit to patients and families?
No. They know. And I'm not sure if they asked maybe, and then they know all of a sudden, especially when we got our capper mask, they thought we were Martians. But when they saw that, and when we do the COVID room, we still have to come back in the unit, and we usually would, before the patient comes in, we'd have the capper on, and we would have to do like our pH and conductivity for our dialysate. So the first time they saw us with our like snowsuit on and our capper, they knew. So we didn't disclose it, so to speak, but they know that it's out there in the community, and they know that we must be taking care of somebody. But otherwise, we haven't. They don't really.
They don't ask.
No.
Okay.
No, they don't.
Good.
Yeah.
Got another question. Do you need an order from the MD to get the high dose flu vaccine to all the patients?
We have it in our standing orders now for the last 2 years.
Do you give them to everybody or over 65?
Yeah.
Okay.
No, everybody. The first probably 3 or 4 years ago, we gave it over 65, and then we just put it on for all of our patients for high dose.
Okay.
Mm-hmm.
Thank you.
Thank you.
I think that brings us to our closing wrap-up. Again, thank you very much. Great job on the presentation. Great job on your staff that has done so much hard work and clearly passed the state survey. So
yeah,
that's awesome. Matt, can I have the next slide? And so we're just going to wrap it up here, but I do want to just talk about the Kidney Learning Hub a little bit. This is a secure, mobile-friendly web tool for patients and professionals. It was developed by the ESRD NCC with assistance from patient subject matter experts. It links to a lot of important resources, such as today, COVID-19 information. It talks about transplant, home, dialysis, new ESRD patient education. It also features things like patient grant library. There's a couple videos, understanding high KDPI and increased risk kidneys. So visit us today at thekidneyhub.org and bookmark that to your device or your home screen. Next. And we just wanted to let you know when our next COVID-19 webinar series is. Next week is the patient-focused event. It's October 22nd at 4 p.m. The next provider-focused event is October 28th at 3 p.m. You can always visit kidneycovidinfocenter.com for information and to register for those. Next slide. And again, we just want to thank everybody for attending today, taking time out of your day. I know everybody's busy with COVID-19 and the day-to-day operations in your facilities. But thanks again. I hope it was a valuable presentation. I feel like Mary presented a lot of good tips and a lot of good best practices in her facility that hopefully you can utilize in yours. So thank you. Thank you, everybody. Thank you, Mary. Thank you for attending. Everybody enjoy the rest of the day and be safe.